What I'm going to talk about is, well, why should we share best practice? What actually is it that we need to share? And how should we share that? And I really like this quotation that says, "Everyone is my teacher. Some I seek, some I subconsciously attract. Often I learn simply by observing others. Some may be completely unaware that I am learning from them. Yet I bow deeply in gratitude." Because at the end of the day, every single day is a new school day, isn't it? And if it wasn't, it'd be ferociously boring, wouldn't it? Imagine if you knew everything that was needed to be known, and yet you had to face into the same situation day in, day out, day in, day out. And as somebody who's involved in education and who's really lucky to be involved in education, and also to be lucky to be involved in wound management, if I thought, well, I've said this before, and I've said it before, and I'm saying it again, but I didn't understand that the people who are hearing us have not always heard that message, and they're hearing it in a slightly different way. If we all went to see the movie tonight, we'd all hear a different message from the movie, wouldn't we? And that's the beauty of it, because we are all different. So here I go, Jackie, with the Cochrane review. So this is really important, and I'm not sure, do you all know what this is? I like it, because I can see clearly what it's telling me. And maybe some of you are thinking, well, what is she talking about? But the beauty is that it's a visual depiction of the impact of a particular therapy on neonatal mortality. And what we have here, down here in the centre, is the line of no difference. And everything to the left of the line favours the intervention, and everything to the right of the line doesn't. And anything that touches the line shows that there's no difference between the intervention and the control. And you see where the diamond is here. That diamond is showing you that there is a body of evidence that favours the intervention. Now, the reason why it's important for us to put all the information together and for us to listen to each other and to learn from each other's experiences is this analogy, where despite the fact that there were several trials that showed the benefit of corticosteroids, adoption of the treatment was low. And that could be for the very reasons that Jackie said, that some obstetrician in his or her hospital was saying, well, until I find out this information for myself, I'm not listening to the others. So who is Zena Moore in the Royal College of Surgeons in Dublin anyway? So she hasn't got a clue. And wait and wait and wait until I find my information. However, the systematic review was influential in increasing the use of the treatment. And it shows that corticosteroids given to women who are about to give birth prematurely can save the life of the newborn child. Now, all of us were newborn children once upon a time. And for some of you, a lot more recently than it was for me. I hope I don't look like it was too long ago. Nearly my birthday. So the result of the meta-analysis, which is what we're looking at here, of the available trials showed a reduction in the odds of death in the babies of these women by 30 to 50%. So it's really important that we know that. And by listening to the trials of other people, instead of saying, I must do my own little trial till I can find out, the problem with that was they weren't adopting it, and yet look what could happen by adopting it. So you can see how at the outset it is important for us. And so why we share expertise is because clinical expertise is closely related to quality and patient safety. And at the end of the day, all of us are users of the health service, and we would like to think that if, touch wood now, and I hope I don't get one, if I keep moving around I might not, get a leg ulcer, we would hope that we would be offered expert care, considering all that we've known now than was there 20 or 30 years ago, and that we would be treated with quality and patient safety at heart. And clinical expertise develops when theoretical and practical knowledge are tested, and importantly, they are tested within the clinical situation. So Zena could be in her ivory tower in the Royal College of Surgeons in Dublin, there on St. Stephen's Green, beautiful location, and I could be typing away from now till Christmas, 12 months. But what difference would that make if the information is not tried and tested within the clinical arena? Does that make sense to you? Because at the end of the day, every single one of us are interested in patient care. So in the Royal College of Surgeons there a couple of weeks ago, in came 550 undergraduate medicine, pharmacy and physiotherapy. In the school there, we only have postgraduate nurses, not only because there are 550 postgraduate nurses, so over 1,000 people starting their studies. And every one of them is on the same journey, to be able to meet a patient and to know what to do, when to do it, how to do it, and more importantly, to evaluate it and to do so including the patient in all of their decision making. And that's what we would hope would happen. Because patients, you and me, all of us, have rights. We have a right to access high quality service on the basis of specification and observance of specific, precise standards of care. So you would hate to think that you'd go to the GP, and depending which GP you saw, say, in a practice of GPs, you went with your headache, somebody would say, take 2 paracetamol, somebody else would say, are you stressed? And somebody else would say, maybe you're stressed, let's check your blood pressure, let's outrule any underlying problems you might have, and let's see what's going on with you. Now, which one would you prefer? The one who is abiding by the standards and knowing that every headache is not the same. Each individual has the right to be free from harm caused by poor functioning of health services. And one of the reasons why harm occurs is often because there is poor functioning. But also that each individual has the right to diagnostic or therapeutic programs tailored as much as possible to his or her personal needs. So maybe the patient that Jackie spoke about who had the black heel didn't like the shoes. They were horrible. Maybe, I'm not saying they were, I didn't see them. And so was never going to wear them. But we didn't understand that. So by not understanding where the patient is coming from, we have a false impression about what they're going to do. So can I tell you that I'm not going to wear 4-layer compression bandaging? Just so you know, in case I'm ever there. I would like to shower every single day. Is that okay? So could you come up with an alternate plan for me, and I know you can, that's why I'm saying it, so that I can be happy, you can be happy, and hopefully I'll do well. Because if you put me in 4-layer, I'm going to be going bananas. And by the time it comes to Saturday night, I'm going to say, well, I won't say the words I might say, but I'll say, no way, Jose, haha, I'm not going to wear it. So do you understand that it's important to realise where people are coming from? And so the challenge, of course, as you know, is that, these are data from the United Kingdom, shows that on average, 1 incident of patient harm is reported every 35 seconds. About 1 in 10 hospitalised patients experiences harm with at least 50% preventability. There are 421 million hospitalisations in the world and approximately 42.7 million adverse events occur during these hospitalisations. And in Europe, about 15% of hospital expenditure can be attributed to treating these safety events, which many of them could have been preventable. And that's Jackie's analogy of the money going down the toilet. Because if we didn't have this happen, then we would have had more money to spend on interventions we require. Providing they don't cut your budget because you did so well last year. That's not proactive, is it? Because then you could, like in your hand to your heart, you're sitting away reflecting, saying, why would I do that? All they're going to do is give me 50% less than last year. And the Global Patient Safety Network says in order for us to make a difference to patient safety, we have to encourage leadership commitment. So we know that has to come from the top. So to take the analogy of why our voice isn't big enough, people have to appreciate how important wound care is. If they don't understand that from a population health perspective, then you and I will be banging our heads off the wall, only getting our message across to certain people. We need to collect evidence from various standpoints to inform our future policies and practice, strengthen knowledge transfer and technical capacity, institutionalised patient safety for sustainability, and importantly, we have to encourage the sharing and application of best practices. So when Ellie asked me to speak about this, She's clearly on the ball in understanding the importance of sharing what is best practice. So here's some studies from Ireland. So for wounds that were necrotic in this survey that was undertaken, 38% of these wounds had a non-adherent dressing applied. So Jackie taught us about all the dressings that are there. Now surely there's a better availability of a product if you're going to use sort of like, moist wound therapy for debridement, then is that the most appropriate dressing to choose? Of the highly exuding wounds, 31% were dressed with a low absorbent dressing. Imagine that was you and it's leaking all over the place and somebody standing there saying, I don't understand that. Why is that? But of course you've used the wrong dressing. For the low exuding wounds, 31% were dressed with a highly absorptive dressing. And for those that were non-infected, an antimicrobial dressing was used as the primary wound dressing in 42% of the cases. So it's no wonder that the cost of antimicrobials is rising, and that somebody from the outside looking in could say it's not making any difference. But of course it's not, because you're using them in the wrong case. So it's no wonder then that the costs are rising. And here, just to highlight, because what Alan was saying was that this should never have happened. Somebody has a wound for more than 5 years with no diagnosis, and a nurse is going in and out and in and out and in and out to the home managing that patient. And another study by Jordan O'Brien et al., there's about only 41% of the patients with a leg ulcer had Doppler. 67% were managed with compression. Now, some of them are being managed without any diagnosis, a proper diagnosis. Of the diabetic foot ulcer patients, 39% were receiving offloading. And of those non-infected, many of them are using antimicrobial dressing. So in 2 different studies, in 2 different locations, and you might say, well, Zena, that's Ireland. Sorry about you. We're great rugby players. I'm so lucky, aren't I, standing here? But maybe we're not so good at wound care. So, the reality for sharing best practice is that we need help, don't we? Because when you're stuck, when you're afraid, when you've come across something you don't know before, we've got to call somebody, don't we? Somebody who's going to be able to share their expertise with us so that we can then be able to practice more effectively. But it asks you the question, well, what is expertise? Because I know when I started in A&E years and years and donkey's years ago, I worked in A&E first after I qualified for about a year or 2. And I'm in nursing like 31 years, okay? So that'll tell you how long ago it was. And a patient came in with a wound, and somebody told me to cleanse it with betadine. Cleansing it with betadine. Somebody else came in, ate the head off me and told me I should have used saline. There were no standards, no guidelines. I hadn't a clue. What do you think I would have done the next time? It's over to you, Mark. That's your wound. I wouldn't have done it because I would have been afraid, wouldn't I? So what is the expertise? Who of them was right and who of them was wrong? And I remember a nurse once saying, when a patient's wound bled, she said to them, that's great. You have a good blood supply to your wound. And it was many years later I studied in Cardiff and I learned the physiology of wound repair. And I know it's a physiological inexactitude that your wound should bleed 6 weeks after it occurred. Something is wrong. But clearly, the person who was an expert, because she was more senior than me, wasn't actually an expert in the field of wound care. She had many areas of expertise, but maybe not in that one. So what individual expertise means, it's the proficiency and judgment that clinicians acquire through their clinical experience and clinical practice. And increased expertise is reflected in many ways, just like Alan told us. Effective and efficient diagnosis, thoughtful identification, and I did hear a lot of compassion about where the patient was coming from, respecting their dignity. All of this came very, very much through what he was saying. Looking at their rights and their preferences in making clinical decisions about care. And so, expertise and evidence-based practice are a hand in a glove, whether we like to really think about it or not, or we're a bit nervous about it. So we know from Sackett that evidence-based practice is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of patients. And it means integrating your clinical expertise with the best available external evidence, and ideally that should come from systematic research, where that is available. And so it leads us, sorry, I'm glad Jackie left now, because here I go with my hierarchy. But I consider this to be very important, okay? And I'm not saying to you that I'm advocating that for every single thing we need a randomised controlled trial, okay? However, what I would like to point out to you about the hierarchy of evidence is one has to be aware of the margin for bias. Now, I'll give you an example of bias. For me, Paul O'Connell, who was the captain of the Irish rugby team, is the best rugby player coming out of Ireland ever. Okay? Everybody got that? Then I asked myself, why is Brian O'Driscoll the voice for Rugby 2023? I want to go up and say to the IRFU, you're wrong. And they'll say, go away, Zena. You're only just one person. So I am biased in my thinking. I really like Paul O'Connell. And actually, he's a great guy. He's a real inspiration, a great guy. But so is Brian O'Driscoll. He's a fantastic player, an absolutely amazing athlete. So bias means that we have a consistent deviation from the truth. But in the case of Brian and Paul, it's hard to know what is the truth, isn't it? So how are we going to measure that? By the number of tries they score? Well, poor old Paul is huge. It wasn't his role to score tries. Sure wasn't. It was Brian's role to score tries. So if Brian wasn't scoring them and Paul was, that could be a measure. But the point is, in terms of research, if we have a biased view on it, then we may be making decisions incorrectly. So if we put all the evidence in a weighing scales, and on the one side, you know, in old-fashioned weighing scales, and on the one side you have all of the studies that show us that the product works. But we didn't have any of the unpublished studies that took more than 5 years to come to the evidence, printed evidence, because we know statistically that statistically significant findings get in first, then statistically non-significant findings. So if we're only measuring it on what we're reading, we might miss, and we might make a decision because the evidence appears this way, but if we knew all of the evidence, it might tell us a different story, such as the corticosteroid story, until it was all put in together. And when we're looking at bias, we need to understand how the study was conducted, who it was conducted on, when, where, in what settings. And it's not that we want to replicate it in Ireland, but one of the biggest challenges we have is that the studies are too small. And we can't see a difference should one exist. An example, not of dressings. Now, Mark is going to confirm for you that my husband is alive when I tell you this story. But imagine if I was in court tomorrow for murdering my husband, and I was found not guilty because of a lack of evidence. It doesn't mean I didn't do it. So when Jackie was talking about, and she's right, talking about the Cochrane reviews, and she said that in many cases they don't have enough evidence to tell us whether the product works. They also don't have any evidence to tell you that the product does not work. Just remember that the next time the materials manager says to you, where's the RCT to say it works? You say, there is no RCT to say it doesn't work. Do you see? So it's two sides of the one coin that we need to understand. So just an example, and Jackie told us this, so there is evidence that compression therapy works. We don't have to argue about this anymore. It works. Use it. Why not? There may be reasons. Can't afford it, can't access it, don't know how to use it, no underlying diagnosis possible. So then we would have to step back from our service and say, well, how would we demonstrate a need for this? So if the nursing home story that Jackie was talking about, or who was talking about the nursing home story, we would have to go in and audit and say, how many patients with leg ulcers do they get there that we need to train them? Or who would we train in order to have sustainability of this going forward? However, it's unclear whether interventions designed to help people adhere to compression therapy improves venous leg ulcer healing and reduces recurrence. There's a lack of trials of interventions that promote adherence to compression, and there is some evidence that compression hosiery might prevent ulcers, but the evidence is not strong. Now, it doesn't mean we don't do this. It just means that if you wanted to sit down tomorrow to buy a new car and you wanted to know, was the Ferrari better than the Merc? I'd say, lucky you. I was thinking of a Mazda myself. However, you would have to say, well, what's the evidence to say that one is better than the other in making my decision? But you still needed a car, didn't you? So you're going to have a car. So same here. We can't ignore the person, and we know so much now about phlebology and the importance of treating the underlying problem, not just the symptom. So maybe we were on the wrong end of the stick altogether. Do you know what I'm saying? So we need to think about that. So what it means for us is that to listen to your instincts, press 1. Because at the end of the day, you have a patient who requires care. You can't say to her, you sit tight there now, and I'll be back in 6 years when we have the evidence to manage your problem. Because in those 6 years, the patient requires care. So there are guidelines, loads of them. And I know we talked about the NICE guidelines. I just want to show that there are other ones. So what have these people done for us? It's a bit like the Romans, isn't it? But clearly they've done a lot for us, because they have given us a synthesis of the evidence to be able to show us what we should actually do when we're not clear. When I started in wound management, it was 1990. Sorry about that. I was there a long time. And I took Steve Thomas's book, Wound Management and Dressings. And that was my Bible under my right arm everywhere I went. Because I hadn't a clue. I'm telling you the truth. I didn't have a clue. I landed into the role. And then I said, okay, I need to know something, like which dressing, why and when. And lucky for me, the European Wound Management Association was born at that time. And so I kind of serendipitously, as they say, it was a fortunate wind blew me there. Because then came all of this information that really helped me in my practice. So how should we share wound management expertise? So there's lots of ways in which we could share them. And you can see the list of them here. Patient-mediated interventions, audit and feedback, conferences, local consensus, etc., etc. And so there is evidence from a systematic review that in general, passive approaches are generally ineffective. And that's why Ellie emphasises all the time about having workshops, because they enable active engagement with the information. And that tends to work, better when you combine both like that. Most other interventions are effective under some circumstances, but none are effective in all. So you've got to think about different ways of delivering what you want to deliver. Promising approaches include educational outreach. So that would be going, like the story we heard about the nursing home, going out to them there, living their experience with them, finding out what the challenges they have in terms of their practice, and then saying, how best could we help them here? Multifaceted interventions are probably better at targeting the barriers than our single interventions. So that might mean that you would have, for example, formal information, practical information, then you'd go with audit and feedback, and then you'd come back and you'd get back the experiences, what's working for you, what's not working for you, rather than just saying, here is the Holy Bible according to wound care, and we'd say in Ireland, Slán leat agus beannacht déir, which means goodbye and God bless. And that couldn't work because the person doesn't even know which page to go to. So you need help in terms of being able to synthesize that for what it means for your practice in your area. And another systematic review once again reiterates the importance of educational outreach, and then they consistently provide small changes, for example in prescribing, which actually may be potentially advantageous to hundreds of patients. So if our prescribing practices improve, then we are going to make a significant difference to patients' lives. For other types of professional practice, screening tests, for example, outreach visits provide small to moderate changes in practice, but the effect is varied, and that'll depend, as Jackie is always talking about, is the willingness of the person you're teaching to accept and take on board the information. And remember that when people are being asked to change, they have to accept the accountability for the outcome of the change. So say you've been doing compression therapy a particular way, and you've learned gently that that's not the best way. So the first time you used the new way, you were nervous. And then you might have said, come back to me tomorrow so I can just check that you're okay. Now the patient is grand, but it's your own self, because you're the person who's lying on the pillow at night time worrying. And I'm sure you have had that experience, haven't you? Like it happened to me one time in practice where a patient's, not a relative, and she wasn't really either the patient's spokesperson, but she telephoned me and she said, you are the tissue viability nurse in this hospital. How did this patient get a black heel? And what do you think I did? I was totally devastated, like, how did they, was it my fault? What systems did we not have in place? And in reality, the patient was very ill with multiple comorbidities. And it might have been that she should never have had the type of surgery she was having in the first place. Because if we had had Alan would have said, probably not the best candidate at the moment for this surgery, because nobody at that time was thinking about the risk in the surgery, the risk of pressure ulcer development. So when the patient was consented, that element was not discussed with her. So do you see how you automatically take it all on board yourself? But it's only when you start to see the big picture that you can see the elements that are coming into play. And it's like the Swiss cheese model. So when it's all lined up, it's why the patient got a pressure ulcer. Whereas had we stepped back from it in the beginning and really thought about her care in an interdisciplinary meeting, it might have been decided not for her to have the surgery, because she spent the last months of her life in terrible pain. And when I saw her one time vomiting in the toilet in the A&E department, I have never forgotten it. Ever, ever, ever. And I do reflect and ask, what could we have done better? And that's the bottom line. So, in essence, when we are thinking about sharing best practice, we need to think about the message that we are trying to give across. And our colleague last night, I'm sure you won't mind me saying, but when he was delivering the after-dinner speech, he was nervous because he said he had never done this before. And in the usual way he gave messages was he'd have his PowerPoint slide up here, ever so confident, practiced everything, and he knows his subject back to front. Whereas here he was in an unfamiliar situation where he wasn't really going to be able to judge what the reaction was until afterwards. And so he tailored his message to us, and I thought he tailored it extremely well. He was funny, he wasn't too long, do you know, the way he was succinct, to the point, and then we could all get on with our dinner. But nonetheless, he sort of did give us some joviality, I thought. He was excellent. So he thought carefully about the message he wanted to bring across, and we need to do that. Because the second thing that we need to think about is, well, who is the audience that we are speaking to? So if we are speaking to patients, then clearly some of them are going to take what you say as absolute gospel truth. And they will write down that you said, keep the skin moist. And they won't know what you mean by moist. Or they might think, she said, dry the skin and keep it moist. Or when we were doing the Pressure Ulcer to Zero campaign in Ireland, we're still doing it, one of the girls did a qualitative study looking at patients and families and carers' involvement in the Pressure Ulcer to Zero campaign. And she said to the patients, and she said, do you know what skin is? And the patients said to themselves, oh Lord, now here's a nurse asking me, do I know what skin is? And sure, haven't I covered in it? But what she was talking about was the skin bundle. Skin, S-S-K-I-N. And the patient didn't know about it. But the patient was the centre of the Pressure Ulcer to Zero campaign and didn't even know the intervention, what it was called. So the point is that the message wasn't getting across. And actually, there was a poster there beside the patient that said skin. But the patient didn't know what that was. Nobody had told them. So we need to be sure. And remember, in many cases, the message might be the actual purchaser. It could be your finance team. Now, your finance team underlying do care about quality of life, but right now they're caring about their budget. So if you can't articulate your message in a way that makes sense to them, what you're trying to disseminate won't get across. And have you ever sat in a room where you're lost at the very first second? Somebody puts maybe a maths quotation, or formula, that'd be me now, I'd be totally lost. Or says an abbreviation that you haven't a clue of until the very end. So it's always a good idea to establish what people know and don't know. And never be afraid, as my colleague Declan says, to ask the question. Because as sure as eggs, half the people in the room are asking the same question, but they're afraid to ask it. So, we have to understand where people are coming from. So target our message according to the audience and know who your audience is and what their prior knowledge is and what their preconceived ideas about it. Somebody once said to me, when I was giving a presentation, she said, this is years back, she said, "It's all right for you," she says, "but we live in the real world." So then I was all upset, you see. So I went off and then I did a course where it was about communication. You're probably thinking she didn't need it because she never shuts up. But anyway. And in it, the person said to me, if somebody says to you that they live in the real world, you have a right to say to them, well, my world is very real to me. So I do live in the real world. If you pinch me, like Shylock, Merchant of Venice, if you prick me, do I not bleed? If I am like you in this, surely I resemble you in, etc., etc., etc. So can you see that, but also maybe that was my naivete, that I didn't pitch myself as to where these people were coming from. So using Jackie's advice and guidance, I did reflect on it and then came back to saying that knowledge actually, it's like money. To be of value, it must circulate. And in circulating, it can increase in quantity and hopefully in value. Thank you very much.